Hi, welcome to this webinar and e-poster discussion about diagnostics. This session is being chaired both with myself and Clara Franco. We're very delighted to have a number of very lovely presentations that highlight a lot of different ways diagnostics is being used, both in terms of very laboratory-based and more clinical-based presentations. I'm very pleased to start and ask Safa Baris to start our afternoon off talking about diagnostic modalities based on flow cytometry for LRBA and CTLA-4 deficiencies. Safa, if you'd be kind enough to start.
Yeah, thank you so much. I'm very glad to be participate to this wonderful meeting. So I'm gonna go to the present our study. So I have nothing to disclose. So I will give a summary of the background of the study. So LRBA and CTLA-4 deficiencies presented with susceptible to infections and autoimmunity and lymphoproliferation. Both diseases demonstrate similar immune phenotype that characterized by TREC deficiency. As you know, that the LRBA is guardian for the CTLA-4 and maintain the recycling of CTLA-4 to the cell surface, and then CTLA-4 can act as an immune suppression for the immune system. So both disease, there is a TREC deficiency, and this is make an obstacle for the differentiate between both disease from the clinical perspective, and this make a increased dependency for the genetic testing. So in our study, we aim to investigate the role of flow cytometer to predict the both disease and then provide an early genetic diagnosis. So we recruit the clinical features and we examine the laboratory investigation for the LRBA and CTLA-4 protein expression. We look also for the regulatory T cells, and we also examine the circulating follicular T cells. So this is the demographic and clinical phenotypes of the patients. There is 15 LRBA deficient patients and 12 CTLA-4 deficient patients. Most of them are male, and there is no difference between two groups for the current age and median follow-ups. But when we looked for the median first symptom age, LRBA deficient patients presented earlier than CTLA-4 deficients. And this is the summary of the clinical phenotype when compare both disorders. So they are both presented with recurrent infection and immune regulation, immune dysregulation, and autoimmunity. So there is a difference between in terms for the lower respiratory tract infection, which higher in LRBA deficiency, and also there is a much higher failure to thrive in LRBA deficient patients. So we check the LRBA expression by flow cytometer in both disease, and as expected, LRBA deficient patients showed very low LRBA protein expression when compared to CTLA-4 and healthy control. And also we look for the TREC. So the TREC, it's in both diseases there is a TREC defect. Also, we check the Tregs at unstimulated condition and after stimulation with expander T cell beads after 16 hours. So at baseline, there is no very difference between the both disease and healthy control, but after stimulation, there is an expansion for the Tregs, but it's still lower than healthy control. And we looked for the CTLA-4 expression for both disorders. And interestingly, when we check the baseline protein level of CTLA-4, LRBA deficient patients significantly showed very low CTLA-4 protein expression when compared to CTLA-4 deficient patient and healthy control. But after the stimulation, all patients showed induction of CTLA-4, but they are still lower than healthy control. So I would conclude that LRBA and CTLA-4 disorders have a similar clinical and laboratory overlap manifestation. That's making a dilemma for the diagnosis. So when we analyze the patient with flow cytometer and make a detailed staining for proteins, this will provide early diagnosis for those disorder and can provide a targeted gene sequencing and make an early diagnosis for those disorders.
Thank you very much.
Thank you.
For your presentation and obviously the people you wish to acknowledge. We already have one chat in the question answer, so sorry that I wasn't clear at the beginning. Please enter any questions you have in the Q&A box, and if we have time, we'll answer them. So the question, Safa, the first question is, sorry, I missed it, but what was the stimulation for the Treg expansion?
We used a bead for, we used CD3, CD8, and CD28 beads, T-cell expansion beads.
Do you think, as a follow-on question, do you think that's the best thing to do? Or I know a lot of people, and particularly the group in the Royal Free, use SEB, David Sampson's group, which is a much stronger stimulus. Do you think one is better or worse, or doesn't it really matter?
I think it will be better, but I think also these assays depend on the for the each lab experience. So it could be depend on technical personnel and also lab conditions. So for us, this is the best way, but yes, the others could be stronger stimulation.
Okay, thank you very much. Clara, do you want to introduce the next person?
Yeah, sure. So the next person is Johan Struck, please.
Okay. Well, thank you very much. I'll thank the organizers for giving me the opportunity to present our work here, and this is work on a newborn screening program in Switzerland, and with that, so I've got nothing to disclose. So what I'm going to present very briefly is the first year of the newborn screening program, mainly aimed at detecting early detection of SCID cases in Switzerland. That was introduced in 2019. And for that, we use a combined TREC and KREC assay, and it's done at a national laboratory where all the newborn screening is done in Zurich, where also placed. So the way we do this in a systematic way is that the laboratory, newborn screening laboratory, does the testing on the ones, and if that's normal, so basically that's normal, is not going to be repeated. If that's abnormal, there's going to be on the same card a test in duplicate. And what we're mostly interested in or worried about are these so-called urgent positives. These are patients who have TRECs that are 0 or 1. And this is then when we sort of are called into action and are going to see the patients quite urgently in our clinical department. And so the way it is done is that we all get these phone calls, and then one of us follows this up. And as I said, these urgent positives are the ones with TREC 0 or 1. And we contact the parents, and then always ask them to stop breastfeeding for the moment and then evaluate them mostly at our center or at another center in Switzerland. And what I'm going to tell you now is some early results. So the first year on SCID cases. So we had tested 85,000, just over 85,000 newborns in 2019. we detected 1 boy with A-gamma globulinemia, and then 7 children with a SCID, with a cumulative or with an incidence much higher than we expected. Out of those 7 children, there were 6 boys, and the majority were actually RAC1 deficient patients. 3 of them, 1 patient with a JAK3 deficiency, 1 patient with a common gamma chain, 1 patient with a cartilage hair hyperplasia, and 1 patient who's doesn't have a genetic diagnosis. There's some microduplication in the region of the 22q11, which is not known to result in the SCID, but that's the only thing we actually found. So what happened to those patients? We're very close proximity of the stem cell transplantation unit, and 6 out of those 7 were transplanted already. And at the age of between 3 and 7 months, the outcome was mainly favorable. We are now 6 to 16 months post-transplant for these patients. Unfortunately, 1 child died post-transplant due to a fulminant RSV pneumonia. And this was unfortunate in particular because this was already acquired before we saw the patient for the first time at our center. So this was a very early RSV infection and led to the death of the patient. So I already come to the conclusions and there's some more details on the poster on these patients. So in our first year of a newborn screening program, we have detected a very high incidence of SCID patients, much higher than we anticipated. We benefit of a very centralized system with a close collaboration and also physical proximity of the laboratory, our immunology department, the medical genetics team, and the stem cell transplantation, which makes caring for these complex patients optimal, we believe. And we have implemented a quite rapid and systematic evaluation strategy, also leading to very early genetic diagnosis, which helps us usually get a genetic diagnosis within 10 to 14 days. And with that, I'm happy to take questions.
Thank you very much. So we have a question from the audience. Do you believe that the high incidence of SCID might be due to founder effect?
So there's probably 2 answers to that. One is it's a first year, so that could be also just chance. And we actually have not had that many patients in the second year of screening already, so that will reduce the incidence. And the second point, obviously, is that everyone knows the Swiss type hypergammaglobulinemia, which is so there is a long history of SCID in Switzerland, and although we haven't had that many cases in the past, it might be actually more prevalent in our country. That's possible.
Thank you. And there's another question. So regarding the patient with SCID who died from the pneumonia, which treatments did he receive prior to the transplant? And was the infection under control by the time of the transplant?
So this patient was treated, yes, with multiple treatment, including immunoglobulins and palivizumab and also antivirals, and that was fairly controlled actually when he went into transplant. That's right. Yeah. So he was always positive, never was negative, but then got much worse after transplantation.
Thank you. So there are more questions, but we don't have time for them. We will ask them and discuss them if there is time at the end of the session, and if not, I'm sure you can chat with the presenters in the chat rooms. Thank you.
Thank you very much. It's my pleasure to invite Romain Theonon to present her presentation on association of TRAF3 heterozygous nonsense mutation to tonsillar hyperplasia. Thank you. Romain, I think you're on mute.
Yeah, is it okay? Okay, sorry. So I am Romain Touénon, and the work I am going to present now is about the association of a TREC3 heterozygous nonsense mutation associated to a tonsillar hyperplasia. This work has been carried out in the Human Lymphohematopoiesis Lab in Imagine Institute Paris, France, and in close collaboration also with Professor Benedict Neven from Necker Hospital. So, okay, so I have nothing to disclose. This work is based on the study of two monozygotic twins, which presented with lymphoid hyperplasia affecting tonsil and tongues. And this child presented this phenotype in the early childhood. This hyperplasia was responsible for upper respiratory tract obstruction and sleeping apnea. They both required amyloidectomies and also recurrent adenoidectomies, but unfortunately the biopsies were not kept, so not available for further analysis. They presented recurrent ENT infections and also retropharyngeal abscess and a pneumonia episode in one of the patients. So the human phenotyping, as you can see, revealed a slightly increased number of B cells associated to a slightly increased immunoglobulin titer for IgG and IgM in both patients and IgA in one of them. There were also some defects in the T cells, but our study is mostly based on the B cell. So as we suspected a monogenetic defect underlying this clinical phenotype, we performed the whole exome sequencing as a trio. And the DNA was extracted from peripheral blood mononuclear cells. In parallel, we established a BEV cell lines for further functional analysis. The genetic analysis, as you can see, revealed a de novo variant in TREC3 gene. The presence of this variant found in one patient was confirmed by Sanger sequencing in both of them. The variant is a deletion of two bases within the exon 4 of the TREC gene and induce frame shifts. So, given that TREC3 gene has been described to undergo a high purifying selection and considering its published function in B lymphocyte homeostasis, we consider this heterozygous variant as a very likely candidate for the patient's clinical manifestation. So as you can see here, we found also the mutation at the mRNA level, but we saw that it induces a reduction by 50% of the mRNA quantity in the BOBV cell line derived from the patient cells. Then we investigate at the protein level, and as you can see, we saw a reduction by 50% also of the TREC3 full-length protein. So in B cell, in mature B lymphocyte, TREC3 has been shown to negatively regulate the B cell activating factor receptor mediated non-canonical NF-kappa-B pathway. So as depicted here, you see that under no BAF stimulation, TREC3 acts as a negative regulator of the NIC protein by continuous NIC ubiquitination, promoting its degradation. But under BAF stimulation, TREC3 is sequestered by the BAF receptor activated, and therefore the NIC protein remains active, and its kinase activity enables the release of the p52 protein, which acts itself as a transcriptional factor, inducing the expression of pro-survival factors such as MCL1. So, as you can see here, in X cells expressing ectopic NIC at constant level and TREC3 at increasing level, we were able to demonstrate a dose-dependent negative correlation between NIC and TREC3 protein levels. We then investigated the effect of the TREC3 nonsense mutation on the p52 and MCL1 protein expression in the BOBV cell lines derived from patient cells. So we stimulated these BOBV cell lines with increasing amount of BAF from 0 to 200 nanograms for 4 hours before analysis. At basal level, there is no difference between patients and control cells, but after BAF stimulation, we can see an increase of p52 and MCL1 protein levels under the BAF stimulation. We also observed in those cells an increasing of the IL-10 secretion by BEBV cell lines under BAF stimulation. And in both cases, these increases were BAF dose dependent.
Please, would you finish? Thank you.
Yes, of course. This is my last slide. So herein we provide an evidence for a TREC haploinsufficiency associated to an hypersensitivity of patient BEBV cell lines to BAF stimulation, which results in an increase in NF-kappa B signaling. So thank you.
Thank you very much. A really nice, interesting piece of work. At the moment, no one has any questions, so I'm going to ask a question. So it's another example of haploinsufficiency within these pathways. In this country, we have a lot of consanguineous families, and therefore some of these things that are haploinsufficient in the rest of the world occasionally show up as an autosomal recessive here because they get bad copies from both parents. What do you think the phenotype of something like that would be if you had no TRAF3 at all?
There is no evidence actually of no TRAF3 in human. But for the mouse, for example, a total depletion of the TRAF3 gene is completely lethal. So after 1 week of life, the mice die. So it's very deleterious, and that's also why this gene is under a high purifying selection, since the total depletion is lethal.
Thank you. We had one other question. How do you think haploinsufficiency with tonsillar hyperplasia, what do you think the mechanism of that is?
So I think actually, knowing this response on the NF-kappa-B2 signaling with a higher production of pro-survival factors, maybe they have some B cells that just survive more and so accumulates on this area.
Thank you. I think we need to go on to the next presentation, but thank you very much for a very interesting presentation with a lot of nice functional data.
Thank you.
Thank you. So the next person to present his poster is Dimitri Persin. Please, Dimitri. And you are muted. You need to mute.
Do you see my presentation?
We don't see your presentation.
Why? Just a second.
To Marta and then come back to you, Dimitri. And maybe Vadim from Keynes could try and liaise with you through the chat to try and figure out how to get your presentation back. Marta, are you okay if we go ahead and ask you to present now?
Yeah.
Thank you very much for your flexibility. So Marta, sorry, your screen just popped up. Marta Daphne Cabanaro is going to present granulomatous lymphocytic interstitial lung disease, GLILD, in patients with common variable immunodeficiency, CVID, the clinical and radiological characteristics and risk factors. Thank you very much, Marta.
Okay. So good afternoon, everyone. First of all, we would like to declare no conflicts of interest for the development of this work. Okay, so as you know, common variable immunodeficiency consists of a decrease of immunoglobulin production and also an altered immune response. Since the development of immunoglobulin replacement therapy, there's been a decrease in the number of infections, and therefore the first cause of morbid mortality nowadays are non-infectious complications such as GLILD, which affects up to 1/3 of common variable immunodeficiency patients. GLILD entail high morbidity and mortality, especially because we are not able to predict which patients develop this disease and which patients do not develop this disease. That's why the aim of our study was to evaluate clinical and therapeutic features of patients with common variable immunodeficiency and describe independent predictive factors for GLILD development by means of a retrospective case control study. We chose 29 patients with common variable immunodeficiency, 7 with GLILD and 22 without GLILD. And we analyzed many variables such as demographic parameters, respiratory, pathological, analytical, radiological parameters, and complications, non-infectious complications, and also the treatment they received. We perform a descriptive analysis and also a multivariable regression model carried out with SPSS software. So the variables that achieve statistical significance, which means that were different in cases with respect with controls, were the parenchymal lung involvement, which was present in 100% of cases and only in 33% of controls, the number of polyadenopathies, which were present in 85% of cases and only in 3 controls out of 22, the presence of splenomegaly, which affected 85% of cases and only 20% of controls. And also regarding analytical parameters, 57 cases show autoimmune hemolytic anemia and no controls at all show this disease. The number of CD8 and the number of CD19 lymphocytes were lower in cases with respect to controls. But when we perform the statistical regression model, only polyadenopathies, parenchymal involvement, and splenomegaly show as independent predictor factors for the development of GLILD. So to discuss, as I said before, GLILD entails a high morbidity and mortality, especially because of the diagnostic delay this disease has. That's why we developed this predictive model in which if we have a patient with common variable immunodeficiency that develops lung parenchymal involvement, splenomegaly, and or lymphadenopathies, we should suspect the development of GLILD. As well, nowadays the diagnostic gold standard is still lung biopsy, which entails, again, morbidity and mortality. And here we propose this alternative diagnostic algorithm that still has to be proven in many patients before being applicable to clinical practice. And in here we propose also the biopsy of lymphadenopathies, as we consider GLILD to be part of a generalized lymphoid hyperplasia. So if we have a patient with common variable immunodeficiency, adenopathies, and splenomegaly, we should perform a CT scan. That if this CT scan shows parenchymal involvement, then we can perform a lymphadenopathy biopsy, which can lead us to diagnosis or not. And in case we don't achieve diagnosis, we should perform lung biopsy. So to conclude, we consider that GLILD could be a pulmonary expression of a systemic pathology characterized by lymphoid hyperplasia and the presence of granulomas. Therefore, less invasive methods such as lymphadenopathy biopsy could be performed for its diagnosis. And the presence of lymphadenopathies, splenomegaly, and interstitial lung involvement should make the practitioner suspect a possible presence of GLILD in order to establish prompt treatment and also to decrease the mortality this disease has. Thank you.
Thank you very much, Marta. That's a really interesting presentation, and to try and decrease lung biopsies, if you can do it, would be a really useful thing. So right now you're still gathering data. Do you know if your algorithm would miss anyone? You might send more to lung biopsies than are needed, but are you going to miss anyone?
Well, what do you mean with missing everyone? Like
if you follow that algorithm,
yeah.
So lung biopsies at the bottom. But do you think you would pick up all your GLILD patients by following that algorithm, or do you think it'll pick up 90% of the GLILD patients? Or
we think everyone, because the last part of the algorithm is again lung biopsy, which nowadays is the gold standard. So it's like a pre-phase before lung biopsy, which will take part the lymphadenopathy, which is less mortality and morbidity.
Yeah, I think I was wondering if you stop because they don't have one of the features up above. So would you have someone who has a diagnostic lymph node biopsy and might also have GLILD, for example?
Yeah, we think that the lymphadenopathy is more sensible but less specific. And then everyone has lung involvement. So we think we will not miss any patient at all. But that still has to be proven in many more patients.
No, but it's a very nice algorithm piece of work. Thank you very much, Marta. I don't think there's any other questions for Marta. Clara and Dimitri, do you want to try again?
We will leave Dimitri for the end of the session.
Okay, we'll leave Dimitri at the end of the session. Sorry.
Yeah, we are moving now to Selima, please. Selima Olsen.
Yeah.
Thank you.
Hello. I will try to present you a patient who met the criteria of both TREC and macrophage activating syndrome. The title of my presentation is Which one is guilty in development of DRESS in a patient with TNF RSF1-3B and MEFV gene mutation, drug or mutation? There is no disclosure. If you look at the clinical manifestation of our patient, he was a 10-year-old. We have been followed him with the diagnosis of common variable immunodeficiency and familial Mediterranean fever. Both TNF RSF1-3B and E148Q heterozygote mutations were defined in his genetic analysis. And we also know that both autosomal dominant or autosomal recessive mutations of TNF RSF1-3B cause TACI deficiency, which is one of a CVID phenotype. And our patient met the criteria of CVID for ESID criteria. So regularly intravenous immunoglobulin replacement treatment have been performing for our patients for 6 weeks intervals. And he had also E148Q heterozygote mutations and compatible clinical manifestation with FMF, so that colchicine treatment was started 4 years ago by a pediatric rheumatologist for our patient. Nearly 6 months ago, he was hospitalized because of pneumonia, and 5% azobactam treatment was started for him. The 14th day of treatment, new-onset resistant fever, lymphadenopathy, splenomegaly, and maculopapular cutaneous lesions were developed. Here we can see the cutaneous lesions of our patient. In his complete blood count, anemia, eosinophilia, and thrombocytopenia were present, and his liver enzymes reached at 2,000 units per liter. Triglycerides, CRP, and ferritin were high, and coagulopathy was present. Fibrinogen was low, and the dimer reached so high levels. There was no proven viral infection. With this clinical manifestation and laboratory findings, our patient met the criteria of both HLH and register criteria for DRESS syndrome. So what was the diagnosis? Macrophages activation syndrome or DRESS, and which one is guilty, drug or gene mutation? Macrophage activation syndrome is a form of HLH in the setting of rheumatologic diseases, and the etiology of these diseases is impaired cytotoxic function of natural killer cell and cytotoxic lymphocytes that normally inhibit macrophages. The rest is drug-induced type 4 hypersensitivity reaction and drug-specific CD4 and CD8 T cells, and dysfunction of regulatory T cells roles on these diseases. They both involve immune dysregulation, frequently associated with fever, rash, multi-organ involvement, and viral infection reactivation, and they are both potentially life-threatening syndromes. There is a review in literature written on overlap between HLH and DRESS, and in recent studies, it has been shown that the TACI mutations leads to an altered macrophage phenotype, and recurrent macrophage activation syndrome related with heterozygote TACI mutation has been defined in literature. And association between macrophage activating syndrome and inflammatory syndrome has been defined too. It is considered that the MEFV morphisms are modifier genes and predisposed to inflammatory reactions. The recommended therapy for life-threatening forms of DRESS and macrophage activation syndrome are the same. For our patients, 5% azobactam was stopped rapidly, and high-dose intravenous immunoglobulin and plasmethylprednisolone were performed. First day of treatment, clinical symptoms disappeared and laboratory abnormalities normalized, but symptoms of cardiac failure appeared. After steroid and inotropic treatment for a long time, he was discharged with healing. Patch test was planned with 5% azobactam at 6 months later. Besides this, it is known that sensitivity of patch test for diagnosis of DRESS is low, however, specificity is high, so it was difficult to explain the pathogenesis of clinical manifestation for this patient. Thanks a lot.
Thank you. While we get some questions from the audience, I think we could open a debate whether your patient really has a FMF or not due to the mutation identified. I mean, I know it's done. I know that this mutation is also considered like an unknown significance and a variant that is commonly found in patients. But my question would be, did you do other genetic studies, or how did you find these mutations? Because could we have another gene here affecting and giving this phenotype?
We used the new sequence generation analysis for primary immunodeficiencies. There is a panel for nearly 258 56 mutation, and we determined with this sequence analysis.
Okay, so in your opinion, was it a dress, so bad effect from the drug, or is it caused by a primary defect?
With the patch test, if we find positive, maybe it will be helpful for the consideration, but it is not real net.
Okay, thank you. So we don't have any questions from the audience now, so we can move to the next one unless Kimberly has a question.
No, we'll move on. So it's my pleasure to introduce Victoria Vedmaskaya to speak about flow cytometry assessment of SAP and ZIAP expression as a diagnosis and monitoring for XLP. Victoria, please start.
Hello. I would like to thank the organizers to present our data. Screening of intercellular proteins expression by flow cytometry represents a fast, robust, reproducible, and sensitive method for diagnostics of primary immunodeficiency disorders. X-linked lymphoproliferative syndrome is a severe primary immunodeficiency characterized by hemophagocytic lymphohistiocytosis, dysglomerulonenemia, symptoms of immune dysregulation, and benign and malignant lymphoproliferation. The two most frequent forms of XLP is XLP1 and 2 are caused respectively by mutation in the SH2D1A gene coding for SET protein and CVID gene coding for CVID protein. At the moment, hematopoietic stem cell transplantation is the only curative therapy for XLP. We performed a study of SET and CVID expression and its features in potential patients and carriers of mutation in XLP-related genes by flow cytometry method. Blood samples of patients suspicious of XLP and female relatives of the patients with genetically confirmed XLP diagnostics were studied. Reference values of protein expression were developed in our laboratory in the group of healthy donors. Intercellular staining was performed with monoclonal anti-SAP and anti-CA antibodies, followed by fluorochrome conjugated secondary antibody. Proportion of T and NK cells expression SAP or CA was analyzed by flow cytometry and compared with normal controls. For all XLP1 and XLP2 patients and female carriers mutation or of relevant genes were verified by central sequencing. Here you can see examples, histograms demonstrating CEP expression in T and NK cells of normal, control, and XLP1 patients. 8 patients demonstrated absence or very low CEP expression. On this slide, you can see examples histogram demonstrating CEP expression in T and NK cells of normal control and XLP2 patient. 10 patients show decreased CEP expression. Pathogenic mutations of either SH2D1A or CEP genes were found in all of them. 5 of XLP1 female relatives had B-MODAL CEP expression in their T and NK cells, and 2 of XLP2 female relatives had clear B-MODAL distribution in their lymphocytes, and 6 of female relatives of XLP2 patients had 2 coalescent peaks in CEP expression. Typically, in our study, XLP2 patients displayed residual expression of CEP in some cells population, unlike XLP1 patients who are characterized by lack of expression. XLP1 carriers have clear B-MODAL CEP expression, whereas carriers of CEP mutation in the B-MODAL distribution is not that clear-cut.
Victoria, could you please finish up?
Thank you very much. I would like to acknowledge all the people who participate in this study. Thank you for your attention.
Thank you very much. If anyone has any questions, please put them in the question box. But while we're waiting for any questions to come, you said you had 8 XLP1s and 10 XLP2s. Did they all have different mutations, or did you find some founder effects or some common mutations in either of the populations?
Different mutations.
They all had different mutations.
Yes.
Did you see there's a very common exon 2 deletion in XLP1 patients? Did you see that in any of yours, or were these more missense or stop mutations?
It was different mutations.
Different.
In ASSAY 4 exons.
Thank you very much. If we don't have any more questions, we'll go on to the next presentation. Clara?
Thank you. So let's move to Elena Deri-Papa, who will talk to us about immune deficiencies with DNA repair defects. Thank you. Elena, I think you're muted.
Thank you very much. Dear colleagues, today I will present our single-center experience with patients with PID due to DNA repair defects. PID repair disease is a big group of primary immunodeficiencies with distinct phenotypes, susceptible to radiation with high frequency of oncological complications. In most cases, there is no curative treatment. In the 2018 ICE classification, more than 10 defects were classified in this group. We analyzed 109 patients genetically confirmed to have PID repair disease who were treated in our center between 2012 and June of 2020. The group included 44 patients with Nijmegen breakage syndrome, 52 with ataxial ectasia, 5 with ICF types 1 and 2, 3 patients with LYBIS4 deficiency, 2 with XACC4 deficiency, 1 with Cernunas deficiency, 1 with MRE11 deficiency, and 1 with Bloom syndrome. Here you can see phenotypic features of patients with Nijmegen breakage syndrome, Bloom syndrome, and ICF type 1 and 2 syndromes. The median age of diagnosis was 6 years, but in some cases patients were correctly diagnosed only at the age of 18. As a result, the median diagnostic delay was 4 years, with the maximum time from the first symptoms of diagnosis to 17 years. More than 1/3 of the patients develop malignancies. Median age of the development of oncology complications was 8 years. In many of these patients, the oncologist was the first specialist to suspect the PID diagnosis. Infectious complications were present in 70% of all the patients, autoimmune complications in 33% of all the patients. We also studied TREC and KREC levels in 80 patients at the time of the diagnosis. The majority of patients, up to 80%, had TREC and KREC levels lower than cutoff levels. Most of patients with low TREC and KREC belong to NBS and AT deficiency groups. In conclusion, our group of patients with DNA repair disorders is characterized by prominent diagnostic delay despite the typical phenotype and high risk of oncological complications, and most patients demonstrate low TREC and KREC levels, but it requires future investigation. I want to express my gratitude to all the colleagues from Rogachev Center and my chief Anna Sherbina. Thank you for attention.
Thank you very much, Elena, for your nice presentation. While we wait for some questions to come, I would like to ask you your opinion. Like, why do you think there is such a delay in the diagnosis? Is it because there is not good awareness of primary immunodeficiencies in the region, maybe, or?
Our patients go to our clinic in late periods. After that, their treatment from neurologist, pediatrics, and no go to immunologist.
Okay, and is there a TREC or KREC newborn screening already in Russia? Has this yielded the patients?
No, now we have not newborn screening in this group patients, and we hope that in future this patient may be newborn screening too.
Okay, and then the last question also from the audience. Have any of your patients had bone marrow transplantation?
Yes, we have bone marrow transplantation, mostly group of knee breakage syndrome patients, and some patients for ICF deficiency.
Okay.
And
thank you very much. So I think with this one we can move for the final session. Again, coming back to Dimitri, please. Are you ready now?
Yes, I'm ready now.
Good.
Could you hear me? Yeah.
Yes, and we see your screen.
Okay. Thank you for opportunity to participate in this session. Nothing to disclose. Phenotypic heterogeneity of primary immunodeficiency disease is caused not only wide variety of damaged genes of the immune system, but also various genetic phenomena. Characteristic of this group of disease, reverse somatic mosaicism is one of them. As a result, reverse somatic mosaicism, the wild type of a gene damaged by a pathogenic mutation is restored. It changed to normal or to a new sequence of nucleotides, and function or protein expression of cell population corresponds to normal values. Revertant somatic mutation occurrence, it is a well-known phenomena in primary immune deficiencies, especially in severe combined immune deficiency or WISKOTT-ALDRICH syndrome. WISKOTT-ALDRICH syndrome, it is X-linked recessive disease. Mutation in the VASP gene. Disease characterized is microthrombocytopenia, implicant of cell-mediated and humoral immunity, bleeding, eczema, frequent recurrent infection, autoimmune disease, and malignancy. It is well known that flow cytometry, it is a reliable method of assessment WASP protein expression in patients suspected in WISKOTT-ALDRICH syndrome. Here you can see normal WASP expression, green one peak, and in the right, you can see a patient with WASP mutation and absence expression on or very, very low. And sometimes we can see a pattern of B-MODAL expression of WASP protein can be found in accordance with our interlaboratory values. In this situation, one peak reflects normal expression and the other one is markedly reduced. It is also known that two peaks or B-MODAL expression of proteins can occur in female carriers with X-linked diseases. So we aimed to investigate the nature of WASP protein expression in patients with B-MODAL expression. And we studied 8 peripheral blood samples from WASP patients, 7 boys and 1 girl, age from 3 months till 50 years old, with confirmed WASP mutation and with the presence of B-MODAL expression. Assessment, in our assessment, we use commercial antibodies for main population and commercial antibodies for our studying standard flow cytometry protocols for intercellular or surface staying mononuclear cells. All WASP positive cells were isolated by negative selection with beads and magnetic columns. All of these analyzed by cytometer FACS-CANTI2. Separation of the protein positive population was possibly only for 2 patients due to its minority in the others. WAS-gen sequencing was investigated by Sanger sequencing, and X chromosome inactivation in female patient was investigated by Humara assay, the method widely used to determine the clonal origin of the tumor based on different methylation status of the gene called Humara on X chromosome. So, as you can see in this slide, this summary of our patients. Most of our patients have T or NK cells or double negative cells with which positive WASP expression has positive WASP expression. Some of patients restore protein in several cell population. For instance, patient number 3 had partially restored protein in all cell lines except monocytes. And the relative amount of WASP positive population varied from 1 to 20% among lymphocytes. A second mutation, it is last one column, a second mutation was found in the population of WASP positive cells in 2 of 4 patients studied.
Dimitri, you have to finish.
Okay, sorry. Okay, this Humara demonstrated 95% X-inactivation chromosome from girl. It is comparable with the FACS data. And my conclusion, the model expression, it is a good test for confirmation and finding somatic mutation and female with WASP.
Thank you very much. So, in conclusion, I think what you mean is that B-modal expression do not affect or do not correlate with the severity. They are all severe WASP.
No, I suppose, as we mentioned in our investigation, we didn't notice any signs of severity and B-modal expression. With index of expression, MFI, we know about this correlation.
We have a question from the audience. Could the WASP positive T cells be maternally derived in some of the patients?
Maternally derived?
Could they come from the mother?
No, if we are talking about adult, not adult, teen. Yes, if it is a child, newborn, we thought about it, but if we have some 6 years old child with this type of distribution of WASP expression, no, I didn't see that.
Okay, so thank you very much for your presentation. Thanks to all the speakers. Now we have to leave it here. Thank you to all the audience to come here, and I invite you to stay tomorrow because there are the late breakers and many other interesting sessions. So Kimberly, if you want to say goodbye.
Thank you all for your time, and thank the presenters again. Have a lovely evening. And do log on tomorrow.
Goodbye. Thank you.